It's one of those things like it's Sunday morning and I feel like I should just warm up the crowd, but with 20 minutes, we're just gonna have to go full speed ahead. Disclaimer, I am not an economist. I am a physician scientist. I have a master's level training in public policy. So really what I'm going to do is present a case study and ask you to think about the market design opportunities and questions. The disclosures were submitted with my abstract. This slide was carefully crafted in partnership with my good colleagues at the Centers for Medicare and Medicaid Services. Please accept commentary, opinions, ignorance as mine, and do not hold the federal government responsible. Interestingly, under the CMS funding opportunity, one of the expectations was that we would develop a sustainable business model for the innovation that they funded. I'm going to tell you about that in a moment. This unwittingly made me the founder and co-owner of a social impact company called NowPow and the president of a new not-for-profit organization called MapsCore. You'll hear a little bit about those. The funding from the federal government does not support those business activities, and although the University of Chicago holds a small amount of equity in the company, the University of Chicago does not endorse or promote this entity. Okay, co-authors. I'd like to acknowledge two of my co-authors, Liz Tung and Katie Fruin. Raise your hands, who are here. And Liz is a postdoctoral fellow and a mentee of mine, and Katie is a graduate of my lab and just started medical school. We were asked to describe market design approaches to address inequities in health. And what I told Scott that I thought I could do was describe a solution that we designed to increase access to basic human needs resources. And in so doing, I hope are addressing a very important set of inequities that manifest in health and lifespan. We'll share what we're learning about market dysfunction in the process. Nothing like a ground up, hands-on way to learn economics than trying to solve a very endemic problem. And you'll see it will be obvious where we need help from market design experts. So I'm going to start with describing the solution so you have this idea in your head for the rest of the talk. It's going to sound maybe a little bit crazy, but just bear with me. The solution starts with employing youth, local youth from the communities we serve. And the communities we serve here in Chicago are about 16 zip codes on the south and west sides of Chicago. These encompass the highest poverty communities, the communities that have the largest proportion of African American and Hispanic people. And if you ventured anywhere off our campus in the west or the south direction, you might have some idea of how our communities look. So we employ local youth to gather data about every business and organization in our communities, and we employ them annually because, as you know, there are dynamics in this market and things change. The data that the youth collect are then consumed by an information technology solution called HealthyRx. The overarching name of our program, our work, is CommunityRx. CommunityRx is the combination of the youth, MapsCore, and HealthyRx, an electronic prescribing system. Electronic prescribing of everything else. You've probably seen e-prescribing of drugs if you've been to the doctor and you needed a prescription. What if we could electronically prescribe everything else? And that's what HealthyRx does. So we connect up the data the youth collect about community resources. We push them into the electronic medical record system so doctors have access to this information in our real workflows. Patients, every single patient who comes through the door at the end of the visit gets a list of resources in the community pertinent to her health needs, her wellness needs. And how do we know what those needs are? Well, because we can pull data out of the electronic medical record that tells us something about those needs and also tells us where the patient lives and what language she prefers and how old she is. The patients then know about and can make use of local community resources to meet their needs. There's a big problem out there, and I'm going to show that to you, where people just don't know what's there. And then businesses and organizations thrive because they have customers. People know they're there. The right people are using the right resources at the right time. And we thereby strengthen the local economic vitality of a community. Then there are more businesses and organizations to map. We employ more youth next year. This is CommunityRx. This is the idea. You see elements in this idea, perhaps, of collective social impact. You see elements in this idea of engaging with the community we're serving. And you maybe start to see some elements of markets or market design. I see a commons problem, and I'm just going to give you the spoiler alert right now. Katie and I have been thinking about commons and lemons over the last couple of years in the lab. Who pays for this solution? Everybody wants it, and the more people can use it, the happier they are, but who pays? So what's the inequity? Well, the inequity can be measured in lifespan. There are many ways to think about health disparities, but to me, this is the simplest and most disturbing one. 16 years of gap in life expectancy, comparing the people who I can see from my lab in Washington Park to the people who grow up in the wealthier communities of Chicago. And this is not just a Chicago phenomenon. We see this in New York, where we're also working. We would see this in Baltimore or Los Angeles. I think Ed Glazer was here. Yes, is Ed still here? No? Was he speaking yesterday? Yes. Yeah. Okay, so Triumph of the City, right, is his book. He talks about why cities attract people living in poverty. And so as long as cities do that, we're going to see gaps like this if we don't address some underlying problems. I had a small role, but a really fun time working on the Moving to Opportunity study, which I'm sure you know. This experiment, which happened over 15 years, gives us evidence that giving people the opportunity to move, okay, an intent to treat analysis, the opportunity to move actually was associated with modest but potentially important differences or improvements in health outcomes, specifically lower rates of morbid obesity and diabetes. And if we could just address morbid obesity and diabetes, we would probably see a measurable impact on that mortality gap. So this study gives us really the first gold standard evidence that something about our neighborhoods is important for our health. And it's probably the built environment, and it's probably the social environment, and we're thinking about where can we intervene. Ron Anderson's model is fundamental to health services research. So I don't know whether this is one you're familiar with, but it's iterated over the decades. His model looked at health services utilization, and over time has shifted to really focus on the outcomes of health. So let's just call this, this measure here, evaluated health status, let's just call that a 0 or a 1, dead or alive, or maybe prematurely dead or alive. And then let's think about where we might intervene. Over time, based on his empirical work, Ron Anderson identified one component of his model as particularly mutable, particularly sensitive to intervention. And this was the enabling resources. Enabling resources in the community, accessibility, availability and accessibility of resources in the community where people live is going to be a highly mutable determinant of a person's alive or dead or years of life. And so we focus our efforts there. Let's press the lever that is most sensitive to intervention. This is a whole other lecture, but let us just stipulate a concept of basic human needs that comes from Abraham Maslow's work. It's fundamental, and we're focusing for today, although the technologies we're going to talk about and the solutions out there focus on connecting people to all kinds of needs. The terms being used are social determinants of health, unmet social needs, health-related social needs, and today we're talking about a subset of those things, those basic human needs without which you really can't be motivated to do much else. Okay? And people with these basic needs actually are showing up to healthcare because of the Affordable Care Act. More and more of these people are showing up to healthcare. So the basic needs are the physiological needs, there's safety, love and belonging, and I want to point out one important thing, not just because I'm an optimist. It's not just receiving kindness, affection, friendship, love. It's also the opportunity to give. And we see this in our work on hunger in the Children's Hospital. I can tell you more about it later if you want to hear it. People need, even people with their unmet basic needs, need to feel that they can give. So is there something about that giving need that could be leveraged in a market for meeting people's unmet needs? Here are some views of what the community looks like through the perspective of basic needs. These are the food pantries looking mostly at the south side of Chicago. How do we know they're there? Because the youth are mapping them every summer. Here are shelters. These would be homeless shelters, domestic violence shelters. An interesting example of an information asymmetry problem, domestic violence shelters have addresses, but they oftentimes don't want to promote them for the safety of the people sheltered there. But then how does the person who needs to get there know where it is? Okay? And then there are churches. It becomes hard when we put the churches on the map to see the other stuff. And guess what? For every church, there's at least one fast food restaurant. So when we put the churches and the fast food restaurants on the map, how can you even find a food pantry or a shelter? And by the way, churches are an interesting example because they oftentimes also are food pantries. They're also shelters. They have bathrooms. Did you notice excretion is one of the basic human needs? You've experienced this. Doesn't matter if you paid $500 to go to the concert. If you've got to go to the bathroom, you're going to miss the next set, right? So where do people go if they need to excrete? Most of the time, they can't get in the churches because they're not open. So these are the kinds of things we're thinking about when we look at the community from the point of view of basic human needs. Information failure in this market is a multi-level, complex problem, and I'm only going to give you one bit of evidence to support that hypothesis. So MapsCore identified assets of every kind in the community. We did not discriminate. We didn't decide a priori what was a health asset or what wasn't. We mapped everything. And just to give you an example, this is 2012, so the data set is much smaller than it is today, looking at the health services and the human services and the total assets that they mapped. These are the assets we knew about when we bought the best available data. Dun & Bradstreet data, we got charitable statistics data, government data, we assembled it all into spreadsheets, we brought it to the table with our community partners, and people said, there's not a lot of face validity here. My organization hasn't been at that address in 10 years. There's a new business at that address. And it was the observation around the poor quality of these lists that partly prompted us to start employing youth to gather data about the community. So now you've had a couple seconds to look at this, and what you see is we can compare the data that we collect by primary observation with high school students, mind you, to the best available secondary data. And what we can do is calculate a sensitivity using an epidemiologic term. 64% for health services, 72% for human services. This means I, as a physician, trying to refer my patient to a service in the community, I'm going to be wrong 25 to 33% of the time. What if that was the case when we prescribed a drug? And that would be completely intolerable, right? So why we have to ask ourselves, and this is in the philosophical, probably not the economic realm, why do we tolerate this level of information, this poor quality of information about resources that are so critical? So here's the cynical view from healthcare. It was 2013 when this cartoon popped into my mailbox. It's the only treatment option he has under his current health plan. And I would like nothing more than another 15 minutes to tell you all the symbolism I see in this image. But let me just point out, nobody's happy in this scenario. The scenario is barbaric. It's not just the patient. Everybody's dressed like a caveman. And the patient is the one, of course, being thrown off the cliff. The doctors are the ones pushing the patient off the cliff, not because they want to. They feel very distressed and burnt out. And then the people in the background are some important brokers, let's call them. And Liz has been helping us think about brokers. These are social workers, or patient navigators, or community health workers, or case managers. And they have some tools. They're pretty outdated tools. They don't look like digital tools. And they're like, gosh, we know this person needs food. He's got holes in his shoes. We just told him he has diabetes and he needs to take medicine, but he doesn't have enough money to feed his kids. And we don't know what to do, but we all know it's bad. So this is a metaphor I carry around in my brain. And you tell me, does it look like a lemon market? Everybody's sour here, okay? Nobody's getting what they think they should from this market. So these are the participants, and I understand from reading Alvin Roth's book, thank you for the recommendation, I loved it, I'm going to read it again. But you have to understand who are the participants in the market, right? We have the people, these are the people falling off the cliff. They're not meeting their own needs, and they want help, and in this case, they actually showed up for help. So they're a special kind of person with unmet needs. They did the hard work to show up for some health care. Okay? And then there are the helpers. I wanted to call them the pushers, but it seemed a little like it could be misinterpreted when you broadcast this on YouTube. But the helpers are those doctors, dentists, pharmacists, teachers, lawyers, who have another kind of fiduciary responsibility to the person, but they know that there are these underlying unmet need problems, and they feel really badly about it. And they're the ones who say, here's your legal help, or here's your prescription, and we send you out the door, and we know you're falling off a cliff. There are the brokers, and these are the people, the social workers, the case managers, who are employed or otherwise incentivized to try to connect people, to match people to these needs, but they have really poor quality tools. These are the people who actually know how to change lives, but they're spending all of their time shuffling sticky notes around. And then there are the providers. These are the public and private firms that sell or otherwise provide basic human needs resources. And just to give you an example of what some of these providers look like, it might look like a community health center that also has a dentist's office, a subsidized pharmacy, a mock grocery store to teach people how to shop, a fitness center. It looks like a health center from the outside, but the inside also looks like a social services agency. It might be the YMCA. So from the outside, it's a community center, but they're also providing childcare and education. It might be the Greater Chicago Food Depository. It might be CVS, where you can get free vaccinations, which is a part of the basic need to protect against illness. It might be pest control and mold abatement services. These are for-profit, private firms, markets that clear based on price, but usually individually owned, not well marketed, maybe not on the grid. So what is the market problem? It's sort of obvious at this point, but the people with the greatest need for resources cannot access them. And one point that maybe it would be a unique point from my point of view, maybe not, but the expertise of the people suffering the problem has not been tapped to solve these problems. And what our lab does, what we're focused on, is engineering solutions to injustice, together with the people who suffer the injustice. And I can tell you sometimes it's hard to make that sound like science, but it is. And these people need to be engaged in order to solve the market problem. I want to find out at this conference who's doing market design together with the people suffering the problem. I think it's happening in the developing world quite a bit. Resources exist, especially for people who enter the healthcare system. Basic human needs, locations, inventories, and transactions are disproportionately off the grid, especially as we go from location to inventory. And then to transaction, we get more and more off the grid, meaning there's no digital evidence of this, meaning nobody can look at the aggregate supply and demand. And we think we have a shared resources problem, like I said before. Who pays for the solution? It's not that we don't know what the solution is. It's the question is everybody wants it, so nobody wants to pay. There's no reason why, sprinkle a little bit of eBay and add in a little bit of OpenTable.com. We don't have a solution for this problem. The policy environment is rich, and it's complicated, and time is short, but suffice it to say that there are a couple important acts that have influenced the policy environment and that make the time ripe for producing some market design around this problem. I think some of the areas you may not be familiar with, although I know Scott is from some of our collaborative work, is community benefit requirements in the Affordable Care Act that are putting more scrutiny on tax-exempt hospitals to demonstrate how they're meeting the needs of the population they serve and to catalog the resources of the community and to make those known to the populations they've served. I want to say that there is some hope. There is some hope for how market design might be able to solve these problems. And some of the evidence comes from electronic health record adoption. I don't know if anyone here a physician or related to one? Raise your hand. Not even 2 degrees. Has anyone been to a doctor ever? Okay, great. All right, so can you imagine doctors mostly did not want to adopt electronic health records. Why? Okay, there are a whole range of reasons. Like the cynical reason would be messy handwriting is hard to read if you have to go to court. Okay, the practical reason might be it's really expensive to adopt. Okay, another patient-centered reason would be it's really awkward to try to have a therapeutic relationship with a patient with a computer screen between the two of you. There are a whole range of reasons. But there were major policy forces behind adoption of electronic medical records. And who's ever seen technology spread that fast among a very powerful group of people who didn't want the technology? And the large force behind this was the pressures to adopt electronic prescribing of drugs. Why? Well, it'd be safer. Why? Well, insurance companies can keep doctors on formulary if we electronically prescribe drugs. So there are, again, multiple reasons why this adoption happened so quickly. But now that technology is in place, and guess what? Really, one company owns this market on the electronic prescribing of drugs. Now, these are data from this company, so take them with a grain of salt. I couldn't find another source of data. But look at the metadata that gets aggregated once you take an information technology system and put it in place to match people who need drugs to the drugs. You start getting regional networks with 230 million patients representing 71% of the population. We have 61,000 pharmacies, almost all the pharmacies, more than half of US physicians, 7 billion transactions a year. How are these data being used? Well, you can bet that they're being used to discover to decide where are the markets for new drugs, how to better market the drugs, and for a whole variety of other uses. But we thought, why wouldn't it be great if we had something like this for prescribing everything else? So Community RX is about that. It's about engaging participants in building the basic needs inventory. This is maybe the third thing. So the 3 things so far, I think you could maybe hang on this talk. 1, people need to give as well as receive. 2, engage the people suffering the inequity. And 3, can your solution create jobs? Can your market design solution create jobs? Those, I think, are some of the unique things we bring to the table here. We focused on the built assets. We create this IT-based matching system that leverages healthcare visits, and we were supported by this Healthcare Innovation Award. We're not SureScripts, okay? We had a 16 zip code demonstration region. This shows you the 33 sites where over a couple years we were able to deploy this e-prescribing system and the 3 electronic medical record systems that we connected to. And this is how our data starts to look. We reached 33 sites, mostly federally qualified health centers and some sites affiliated with the University of Chicago. We integrate with 3 electronic medical record platforms. Everyone said that would be the impossible thing to do. That was actually the easy thing to do. Okay? So that's a 4th lesson for me, just be naive, okay? Inventoried more than 19,000 places and 15,000 health-related and unmet need-related, basic need-related resources. We generated 253,000 of these prescriptions for more than 113,000 unique individuals, made 8 million individual referrals, engaged more than 260 youth, employed and trained 5 community health workers. So you start to say, like, wow, I'd love to see the metadata on that. Because now we can start to see the geospatial distribution of supply and demand of these kinds of resources. And there's some endogeneity problems with it, but it's just sort of a proof of concept. So what should we do? Should we expand coverage to include basic human needs? Should Medicare be paying for homeless shelter? Should we hold an auction, like, quick, let this guy bid? You know, should we help these cave people identify their true unmet needs and desires? And in fact, there's policy that's starting to expect that healthcare providers do assess these needs and desires. Do we write a matching algorithm? And if you're trying to find the right answer, you can choose more than one. I would say the one that's not right is hold an auction. So let me just sort of wrap up here. This is an exciting new opportunity from the Centers for Medicare and Medicaid Services that starts to look like experimentation that could lead us to some evidence-based market design. So based in part on the Community RX experiment, which was referenced in this paper, to our great delight, we didn't know that would happen, the Centers for Medicare and Medicaid Innovation Center is now considering applications to deploy accountable health communities. And these accountable health communities would look like ecosystems where healthcare is connected to the other sectors supporting basic and other kinds of social needs, where information technology is at the core, where there are some responsible brokers who are held accountable for matching people to these needs. And they're looking at 3 different tracks. Ultimately, it's the 3rd track that I think looks closest to what we're experimenting with now with NowPow and MapScore. So these are the lessons. Conditions are ripe for a functional market solution that matches people and resources for unmet and other social needs. And I think reputations will be important on both sides of the equation. I'll be happy to answer questions about that. The work starts with creating the database and the IT infrastructure. We cannot build the market without the database. So we need information about participants on supply and demand side. We desperately need inventory. We cannot continue to fund the organizations providing for these needs without funding them to do the inventory work. And that's been the problem. It's been that the funding structures, especially for nonprofit organizations, do not include appropriate infrastructure for inventorying. And we must apply rules that incentivize functional behaviors. Incentives are especially needed on the provider side. We need a data-driven inventory of offerings so providers can shape their offerings to the local needs. And we need a quality improvement strategy so we can understand who's doing evidence-based and high-impact care. And there are other areas of market design that I think could reduce inequities, not at all being an expert in market design. We could generate transparency. We could incentivize people with unmet needs to participate. And this is where I think the giving and the reputations come into play. We could promote data-driven investment by funders, payers, and others, and optimize the role of helpers, and especially those brokers. Thank you so much.